Thank you.
Oh, the last one. All right. Looks like we're good to go right now. We're just going to, if Dr. Stewart, when Dr. Stewart gets here, we'll just add in. All right, thank you all for coming this morning. Apologize for getting this little late start, but just wanted to make sure we were trying to give Dr. Stewart, who might be saving lives out there, gonna give him some time to get here, but we'll go ahead and get started. Thank you for joining us for this collaborative panel discussion, conversation, really an opportunity to connect. Oh, that's right. Check. So an opportunity for us to connect with you all. This particular discussion today that's brought primarily by Kate from the Kentucky Equal Justice Center. Want to say something. I wear glasses and I haven't been able to find them. So things are a little blurry. So just being very transparent. You guys in the back look very blurry. And it's going to be okay. I'm okay today. But just wanted to let you know why I'm pausing on things because I'm dealing with a deficit. So harm reduction in the rights of people who use drugs, uplifting care, building bridges to fair health practices. So, I think for the people in the room, this is going to be a really good discussion. Think of it as learning how to reduce the harm, right? Reduce risk of discrimination that usually, sometimes in my opinion, Kay's gonna give us great examples. My opinion is unintended harms. It's things that we do that aren't necessarily something where we're like, I'm out to hurt someone, I'm out to discriminate, I'm out to take away someone's rights. So this is our way of providing a space in the harm reduction lens, which is engage, educate, and empower. Kentucky Harm Reduction Coalition thought it was a fantastic idea to partner with folks who actually protect the rights of our participants and the residents of Kentucky to bring this presentation here and having Dr. Murphy, who is not just this amazing individual in the medical field, you are director for ASAM. But he's also one of our board members, our board chair, co-chair of our board at Kentucky Harm Reduction Coalition, and our fine Dr. Stewart will be joining us later, hopefully, and hopefully everything's okay, too, right? So, without any, okay, and the luncheon, yes, thank you. The luncheon has been supported by one of our amazing partners, Feed Louisville. That's an organization that works on food insecurity in Louisville, Jefferson County primarily. They provide hot meals, cooked meals out of their state-of-the-art kitchen that we went to tour. I used to be on the board for Feed Louisville. But their work is founded again, the principles of harm reduction. So we are so grateful that they've been able to support not just one, but 2 events in less than 72 hours. So they've really been helping us out. Yes, thank you. Brian's got me on, you guys. And we also have Narcan available for everyone that attends, even if you have it in your office space, even if you have it in your workspace, if you're traveling. It's also nice. It's never a such thing as having too much Narcan, And some people be like, oh, I got one. I got some. And I'm like, I got a candy dish of fentanyl test strips, xylazine test strips, and Narcan, because I have a 19-year-old and a soon-to-be 24-year-old, and I have youth that like to come by my house before they go and have fun, right? So it's never a situation where I'm like, I have enough, right? So especially when we're thinking about uncertainty and availability of free Narcan and things that could be in the near future of ours. So with did I do it all? Did I? Okay, and thank you all for joining us on the webinar. You're streaming with us. We're excited. This is our first like real webinar together. So thank you, Kate. This is my opportunity to introduce you, Kate. She could tell us a little bit about herself. I don't think I introduced myself. I am Sharita Walden, the Executive Director for Kentucky Harm Reduction Coalition. And my team is here. We got Director of Operations in the back, Erica, Sarah. Dr. Murphy's daughter, is our media strategist. And then the one who's running the show, our project manager, who's so kind to me all the time, Ryan. I'm so excited to be here. So I want to pass this off to you now, okay, so we can get started, right?
Sounds good.
All right.
My name is Kate Ironholm. I am a staff attorney at the Kentucky Equal Justice Center. And I work in the Substance Use Disorder Discrimination Project, which was started in 2023. I came into this work in January. And I'm really excited to be here today with one of our partners, Kentucky Harm Reduction Coalition, to talk about this in kind of a comprehensive way that includes looking at discrimination for people with substance use disorder, and people who use drugs, and to have some expertise here with Dr. Murphy. So our project's mission is to defend people against discriminatory policies and practices. And as Sharita said, that isn't necessarily that people are out to harm other people. We are all working in systems, right? So there's the healthcare system, the legal system. We are actors within those systems, and those policies and practices aren't necessarily based in evidence-based and best practices. And sometimes it's trying to stumble our way through and figure out how do we apply that in situations. And so our goal is to address those situations. So KEJC, just a little bit about that. A lot of people in Louisville aren't familiar with KEJC. We were founded in 1976 to work with Kentucky Civil Legal Services or legal aid organizations, doing advocacy work and supporting those organizations. We are based in Lexington, but two of us attorneys are based here in Louisville. So we're a watchdog and advocate for a wide range of issues for low-income Kentuckians. And we do impact litigation, we do advocacy work in Frankfort, and we do some direct services. And so this project that I work in was created in 2023 because while there are many organizations, coalitions, and government agencies who support Kentuckians with SED and use drugs, there are a few who have the capacity to do comprehensive assessment and identification of these issues and to bring impact litigation to help provide people with direct services who are experiencing discrimination. And so we wanted to be a part of the solution to build that capacity and provide those services. One of the impetuses for this is that recognizing that discrimination is one of the barriers that people face and getting treatment for opioid use disorder or substance use disorder. And so we could plug in and be a part of the solution as attorneys there. And so this came about in 2023 after we had a jump in overdose deaths. 49% increase in 2020. And with that finally dropping for the first time in 2023, when this project started, it was improving, but we still have a lot of work to do. And the way that it impacts various groups, rates have gone up for Black and Brown Kentuckians. And so we have to address those disparities as well. And so we work under a grant with Vital Strategies, their overdose prevention program, to build that capacity to work on these issues. Again, this is driven by the way this has been felt in Kentucky. There are a few places that have felt the devastation of opioid-related STD as Kentucky has, and that's in urban, rural areas, but in some counties in Kentucky, at least Kentucky, it's been as high as 18%. So that is what drove us to create this. And so Vital Strategies is a global health organization that believes every person should be protected by a strong public health system. It's funded by Bloomberg Philanthropies, Overdose Prevention, and other programs. And as part of this work, we have grant partners that includes the Kentucky Harm Reduction Coalition. We get technical support from the Legal Action Center, which is an organization in New York that has done a lot of the work to build precedent and support legal protections for people in this space that didn't necessarily exist before. Federal agencies like the DOJ have also really worked hard in the last 5 years to make this a priority. And so there's a lot of protections that didn't exist prior to 5 years earlier. We also partner with Vocal Kentucky and Dream.org. Dream.org has a public health and public safety campaign that works to reduce overdoses through raising awareness, policy advocacy, and harm reduction. And Vocal is an organization that engages in advocacy, organizing, and direct services to work on a variety of issues, including drug policy. So that is our team of partners. We also work with other groups in the community. We have relationships with physicians because often it is frontline healthcare workers who are recognizing things that are happening, not just in healthcare settings, but also carceral settings, so jails and prisons. People come in for care related to withdrawal or another substance use disorder condition. They receive medication, and they go back to their prison or jail and don't receive that continuing care. And so physicians are often the ones who see this discrimination happening and can help plug them into help. So again, the ways that we see this are when people are entering a jail or prison, perhaps they've been living in a recovery setting, they are taking an MOUT, and then they come into, they leave and enter a jail or a prison, and suddenly the medication they've been taking for a year is no longer offered to them. And again, that can happen when someone is returning from getting outside medical care where they've been in a jail or a prison. It happens in accessing healthcare when someone comes into a hospital or a doctor's office, or if someone is trying to enter a recovery home, and a recovery home has a blanket policy that they don't allow people who use medication-assisted treatment to be a part of their program. So I'm going to give just a very broad overview of federal anti-discrimination laws that apply here in this context. Most people are familiar with the Americans with Disabilities Act, or the ADA. But there are also others. There's the Rehabilitation Act of 1973 and the Affordable Care Act. All three of these would apply to hospitals because by virtue of receiving Medicaid or Medicare federal funding. The Americans with Disabilities Act applies to healthcare providers under Title III. And so courts applied all of these in a very similar way. So I'm just going to talk about this as the ADA, but there are protections that come in with these other laws as well. So the ADA is a federal civil rights law that prohibits discrimination against people with disabilities and everyday activities. It prohibits discrimination on the basis of disability, just as other civil rights laws prohibit discrimination on the basis of race, color, sex, national origin, age, and religion. And again, it applies to hospitals and healthcare settings through Title III. So a disability under the ADA is somewhat applies when someone has a physical or mental impairment that substantially limits one or more major life activities. Or they have a history or record of such an impairment, like cancer that's in remission, or they're perceived by others as having an impairment. And so courts have recognized that substance use disorder is a disability. And whether that applies to an individual person, it's done on a case-by-case basis, and whether there is a substantial impairment of one or more life activities. And so most of the time, we're going to find that that is the case. So when is it a protected disability? So by function of the law, and because of stigma, it's not based in evidence or science. It is a function of the way a law was written. It does not apply if a person is currently engaging in illegal drug use. That's not the case with alcohol. So again, these are distinctions without difference, practical difference. But if someone is currently engaging in illegal drug use, that does not qualify as a disability, but it does in the case of alcohol. Importantly, though, regardless of whether a person has SUD recognized as a disability, healthcare providers cannot deny services because of current illegal drug use. So there are protections for people to receive services. If you're providing emergency services in the emergency department, you can't deny service to someone because of their illegal drug use. And so discrimination, just to give a definition, is you have a person with a disability, they are denied the entity services or programs or services, activities because of their disability. And that means that decisions that are made about a person, the problem is we'll get into blanket policies. We don't do this for people with substance use disorder. It is individualized. It is an assessment of that person based on objective medical evidence and not stereotypes or assumptions that are being made. It is based on an individual basis determination. Is this?
It's going, I think it's their system too, so I will just.
I'm sorry for the
I don't know what's happening. Don't grade us on that, y'all. Y'all don't be judging us. We listen and we don't judge, right?
So, generally speaking, what do the laws prohibit? Denying participation or benefits of a service on the basis of disability, denying equal participation, so not just a total denial, but equal participation admission criteria that screen out or tend to screen out people with disabilities. And again, this is another example of something that isn't necessarily intentional, but in practice can be discriminatory. Methods of administration that discriminate against people with disabilities, denying reasonable modifications for people with disabilities, or denying health services due to current illegal use of drugs. So again, it may not rise to the level under the law of a disability, but you cannot deny health services due to current illegal use of drugs. It also includes prohibitions on denial of medical treatment based on bias or stereotypes about a patient's disability, judgments that the individual be a burden on others due to their disability, including caregivers, family, or society, or a belief that the life of a person with a disability has lesser value than the life of a person without, or that their life is not worth living. And not offering treatment that would be offered to a similarly situated person without the underlying disability. So we talk about some examples of discrimination against people with disabilities, and these are based on some real case scenarios. For example, Shane takes buprenorphine for OUD. So in this case, this is a person who had a diagnosis of an OUD, was prescribed a medication, and was taking it, and he was living in recovery housing, or he wanted to live in recovery housing. And so he had a qualified disability under the ADA, but no recovery homes in his area would allow him to take an MOUD. So that blanket policy of not allowing an MOUD in a recovery home is an example of discrimination. Sean had surgery and needed intravenous antibiotic treatment after discharge from the hospital. And although the hospital typically discharges someone needing this care with a peripherally inserted central catheter, or PICC line, the hospital tells Sean that because of his history of substance use, home care is not an option. Yeah, there could be, again, these are based on, these decisions should be made on individual cases. And so there could be a case where that wouldn't be medically indicated, but, or not right for Sean. But in this case, that was not it. And so this was an act of discrimination. Danny went to the ER after an opioid overdose. The ER staff administered naloxone, provided rehydration, and restored her respiratory function. After a few hours, she is discharged. No one offered MOUD, naloxone to reverse a future overdose, or help connect her to OUD care in the community. So again, because Danny was actively using substances, she would not qualify as having a disability under the Americans with Disabilities Act. But she still is entitled to receive services. And so the best practice is to do a warm handoff to make sure she can get connected with care in the community for her OUD, naloxone in case of a future overdose, and to be counseled about the possibility of taking an MOUD. Another example, so I have up here that, recovery home with an abstinence only drug policy. That was the same scenario that I just mentioned. That won't admit Tiffany because of her SUD, because she uses Suboxone for her SUD. Or discharging someone because they start using one. Asking a nursing home for a ride to the clinic so that you can receive methadone, and the nursing home refusing. This is another one that comes up. It's a scenario that happened. A doctor refused to offer Jenny any pain medication after her knee surgery because he was afraid she would start using methamphetamine again. And again, these are individual decisions that are made about a patient's care. But, making a blanket policy, I'm not going to provide medication, is discriminatory.
I wanted to ask, this would be a good part where I was thinking to ask what like organizations or what spaces are represented right now, and do you see any of these that resonate with you? We have folks that are joining us in, I guess they can't really hear me probably. We got folks that are joining us in the space today, and we have folks who are virtually. I know there is an individual that works with as a housing case manager right now, right? So at a local organization called House of Root. So I was just curious about who's in the space. Hello. Okay. I was just curious about who's in the space and if any of this resonates with you. Or what space, what kind of space? You don't even have to say what organization, but it's like residential treatment, just so people kind of know. And we have someone from Kansas on here too, who's over harm reduction in the state. So what spaces do we have here today?
My name is Lindsay, and I work in a unique space that's harm reduction / the connection to treatment and recovery. And I don't know that we see any of these outright when we're attempting to connect someone with treatment or recovery housing. I think maybe some of it can be seen in some of those recovery home standards at times. And I would definitely like to learn a little bit more about how the ADA plays in with fair housing, to know when something is appropriate, when something isn't, so we can advocate for our clients to try to place them.
I'm restricted, I'm with Newly. I do some client coordination and outreach, business stuff there, and I have directly had issues with folks who might need to seek a higher level of care than our transitional housing allows. They will not put their level of care, put denials on if they have a TB or even taking an AT. They're not comfortable with that in their nursing home. And I hate that. And so that's a difficult one. That one kind of rang out to me. So yeah, that's it. Thank you.
Hey y'all, my name is Samantha. I'm with Mobile Recovery Community Connection as well as Recovery Mobile. So what I do is I try to connect people to services wherever they're at, even if they are actively using. And I think one thing that keeps coming up for me is people who use a certain drug are not able to go and seek detox just because of what they're using. That's very disheartening, especially when somebody's ready to get help. And just because they're not using an opiate, they can't seek treatment at certain centers.
Okay, say that. Repeat, put that on ready. Right.
My name is Grace Slawing, and I'm with Addiction Recovery Care. I do hospital assistance. So I would say one of the things is when individuals still need medical assistance and we can assist with, but they're trying to commit to something and we just don't have medical assistance.
Right. Thank you a lot for being here. Y'all making me sneeze.
All right, my name is Takesha Nunez. I'm with the University of Kentucky Target 4 program. We don't really work as far as in the treatment setting, but we are referring people to different treatment providers. So I think that getting this education so that we know the proper ways to refer people or where they can go makes the most sense. Because a lot of times we'll get people and we may send them somewhere, and if they don't have a good experience, then it could be a longer road for them to get back into the idea of going into recovery or going to the spaces that we're wanting them for needing them to go to.
Thank you. One of our partners in harm reduction.
I'm Ryan Jacobs. I work with Takesha as well. I also have experience. I've had experience with specifically your example of the client. I had to advocate for myself just to have that same standard of care, despite my diagnosis, as well as in the recovery housing community where I see where MAT is not considered in a lot of places. So I'm really interested to hear more about that.
And we have someone who did share about themselves on here, just to give Kate a little bit more, because if she needs to spend more time, please feel free to ask her, she's a wealth of knowledge. Lauren Sprigg, House of Ruth is a Housing First organization working with individuals living with HIV. Sobriety is not a requirement for housing, so I'm definitely interested in learning how to best meet them where they are in their journey and ways to advocate for the best overall care and services. So you have a nice variety of folks in space and virtually, and I appreciate all these spaces being in here.
Thank you for asking the question, because I'm really glad to know all of that. So I want to say I'm providing some examples, but this does not mean that you have to be an issue spotter or that we're going to cover all of the possible scenarios. I will have a QR code up here that goes to our intake on our website, and so and my contact information. So if you have questions about specifics, things that come up, or you think I don't know if this is okay, or you have someone you want to refer to us for help, you can always do that, or reach out to us and we can talk about it, about specific scenarios. Yeah, so nursing homes, recovery homes cannot have blanket policies against providing MAT. But often that's what they do, and some of it is they don't understand the regulations and think that they can't, or it's going to be too burdensome. And so some of that is just an education piece. Some of it is a difference in philosophy, or thinking, we're substituting one drug for another. And so again, there's some education work to do there, but it is discriminatory, and it's not okay under federal anti-discrimination. So some examples of, I talked about Danny's example in the emergency department, but another example for someone who is in current drug use, and so wouldn't qualify as having wouldn't qualify as having a disability under anti-discrimination laws, but would still be required to have services provided. Is Pete, who needed a heart valve replacement because he uses heroin. It was clinically appropriate, but he was denied that procedure. So that's another example of discrimination. And we touched on this, but this is an area where the law has really expanded. We have some good precedent and regulations here that support this, making it clear that banning or restricting MOUD is discrimination. And that includes arbitrary dose and duration limits, requirements to switch medication. Well, we'll let you take buprenorphine, but not methadone, surcharges on people taking MOUD, settings where this has been applied in actual cases includes nursing homes, doctor's offices, hospitals, jails, people who are on parole, drug courts, child welfare system, employment, residential work, and social services. So it is a wide range of settings for this.
Someone asked, this is not legal, right? I think it was something you just said, so I'm to clarify.
Yeah, I get some clarification. Yeah, so I was giving examples of things that are not legal.
Okay.
I don't want to confuse people into making that distinction between this is something that is a disability under the ADA, or this is not, but it is still discrimination, illegal discrimination. All these scenarios that I'm laying out are illegal discrimination. And depending on the individual circumstances in the case, and it's something that that can be addressed. So some other examples, specifically talking about MOUD, include refusing to provide a person with an opioid use disorder referral for MOUD due to a provider's belief that the person will not adhere to the treatment protocol. That's discriminatory. A provider's categorical judgment that all patients with a prior history of STD are not qualified to receive medications for pain management would also likely constitute discrimination. And these are individual assessments done on a patient. So in 2020, I think it was last year, but 2022 data among adults needing OUD treatment, only 25% received medications for OUD. 30% received OUD treatment that did not include medications. And of course, higher percentages of white people versus Black, African Americans, and Latino people received any treatment, despite the fact that these groups are disproportionately impacted by this issue. So we have effective treatment strategies, but we've got some work to do to ensure that everyone can receive them.
Okay. And while you're muting it, I would like to share, again, this is more conversational too, is bringing in Dr. Murphy. You want to check your tools.
That's a Microsoft sound.
It's not mine. It's,
Nothing is connected to the.
yeah. I think it's Norton, they got
It's
TikTok.
TV, yeah.
So Dr. Murphy, you know, it has been working on making sure that the expansion of MOUD, which has been very significant. And I wanted to bring Dr. Murphy into this part, not a whole lot, Dr. Murphy, because you got some stuff I want you to share. But as it relates to this, and I saw you take a picture, what's coming up for you as you're thinking about what you're doing? And you can share briefly so the audience can know what it is that you are working.
Okay, thank you. I am a member of the Kentucky Society of Addiction Medicine. So I work on the board of directors of the American Society of Addiction Medicine. I'm a staff physician at Norton and at the University of Louisville. I also I'm speaking right now on behalf of myself, so not for any organization, but suffice it to say, I've got a lot of support from these organizations. I'm a resident of Kentucky, licensed in Kentucky. I'm concerned about Kentucky people getting proper care. We have regulations that get in the way of this at many times. One of the regulations regarding MOUD is the regulation in Kentucky that governs how physicians and nurse practitioners, for example, but right now I'm talking about the physicians, the regulation that governs how they prescribe and whether they're able to prescribe buprenorphine for opioid use disorder. It's been around since 2015. It's very outdated. It's very discriminatory. It's also very much a barrier in care. It's up for renewal at this moment. And for the last year, it has been looked at by the medical board. To review, in 2022, December, the X waiver went away. That's a license that physicians had to get in order to prescribe buprenorphine for opioid use disorder. That's gone. It's been gone, since December of 2022 or in 2025. So that's been the impetus, and the DEA and everybody that's involved in this says we need more access to this medication. Well, Kentucky is one of the few remaining states that has a buprenorphine specific regulation. We're on the verge of getting rid of it. We'll update it substantially to get rid of this, the barriers. June 27th is a public hearing. It's going to be on Zoom. And go on, I'm going to dare say, if you go on the KLA HRC website or any of these websites, you're going to find a link to this Zoom meeting. You can sign up for it. You can express your concern about this. Also, if anybody wants to contact me about this, I'll be glad to explain it in more detail. The various organizations involved in this. And it's a way to, again, lower a major barrier in Kentucky to allowing patients to get buprenorphine to treat opioid use disorder. So that's kind of currently on my mind right now. It's coming up June 27th.
But it married very well, right? Yeah. With you going into a little bit more discussion on it. So thank you for jumping in. I wanted you to see how that marries what you're talking about.
Yes, thank you. Because again, when the fewer restrictions, or well, the more the regulations make sense from a practical standpoint, right? I think it makes it easier for skilled nursing facilities and providers to feel comfortable or to understand how they can comply with their obligation to provide treatment. So under the ADA, if you have a disability, you have a right to reasonable accommodation. That includes healthcare and treatment facilities to provide reasonable accommodations to remove access to barriers for people with disabilities. And that's just a way of saying an adjustment to the way things are usually done to give a person with a disability an equal opportunity to participate in a program and receive services. Sometimes the trouble is that the person who has a disability has to ask for an accommodation. And so the person has to know to do that. And patients don't always know what to ask for. So it's not one, it's sort of it's opt-in, but you have to ask for it. And so that can be a barrier at times. So some examples of STD-related accommodations are asking a facility to modify its abstinence-only drug policy to accommodate your need for prescribed medication. Asking hospital staff to provide you with medicine to assist with the withdrawal symptoms you're experiencing during an extended hospital stay. Asking a facility to transport you to a methadone clinic or recovery support group. Or asking a facility to allow you to use your disability-related personal items or to provide, including service animal, wheelchair, or insulin needles. So some of the reasons, we're going to kind of segue into some Shrita's portion. She's going to talk about some things, but as we kind of slide in there, some reasons for STD discrimination. A lot of it is stigma and misunderstanding about medication-assisted treatment, confusion about MOD regulation and how facilities can provide it, beliefs that people who use drugs have caused their own health conditions and are less worthy of care, lack of education about support, and on top of all the other types of discrimination that people experience, it gets layered in there. Again, we are people working in systems, and we bring the attitudes and norms of society that all comes together, whether or not it's intentional. And I just wanted to highlight some of the some of the barriers to care that are faced by people with SUD that really play into some of these issues as well, including insufficient insurance coverage, too few providers of SUD care, all the ways that we criminalize drug use, prioritize punishment over treating it as a medical issue, lack of mental health services. That's one that I see come up over and over. Substandard housing, not enough housing, how that contributes to homelessness and stigma, which is the big one, and confidentiality concerns. All of these things come together and work as part of this. So I'm going to ask for questions. But we can continue having this conversation. But if anybody has questions now before we transition to Shrita's portion, we can talk about those things. And again, the next thing I will do is put up my information here in this QR code, which takes you to our intake form. So you can use that to connect with us. It doesn't have to be a specific case that's being referred, but if you just have a question and want to get in touch and have a conversation, you can also use that as well. So are there any questions before we move on to?
Yeah, so this doesn't necessarily apply to like MOUD or any of those concerns, but I do have a question regarding, I see this come up over and over and over again when attempting to place someone within recovery housing specifically. What is the obligation of a recovery house to reasonably accommodate someone who is in a wheelchair in varying degrees of being able to perform like ADLs or anything like that? There's maybe one wheelchair accessible recovery house in our entire city. And I just didn't know what their obligation was under the ADA to accommodate someone.
Yeah, that so they are subject to these laws and the Fair Housing Act as well. It is case specific because there could be exceptions. But we can talk about that. I'll make sure you have my information.
And we'll be posting this information for those of you that are joining us online. We'll be posting this information on the streaming app we have and make sure that it's available. We'll be providing a survey at the conclusion of this. It'll be virtual, so you can just fill it out. I'm wondering if if I can turn the volume down. Let me see if that might work. I don't know if my ADHD can handle it.
It got a little distracting.
Yeah, I was watching you. You did a great job. But let's see if that works. All right. So, okay. So lots of information, right? No, that didn't work. We tried. All right, y'all stick with me now. So we got about an hour left. We really want to give time, like I said, for conversation. So if questions come up, my team is on the StreamYard, on our app, for those of you that are online and on our social media platforms and YouTube. When we think about discrimination, like I said, I thought it married well with harm reduction and what our goals are at KYHRC. A lot of people just don't understand that our goal is to reduce the risk. So when we think about having a conversation around attorneys, yes, coming into spaces like hospitals and treatment programs and other social service, a lot of people start getting tense, like, uh-oh, because we think attorney and we think attack, like something's about to happen. Well, no, this is an opportunity for us to really lean into the educate platform. So when Kate and myself and Erica met, we were like, gosh, this is so aligned with how we provide information. The way to reduce risk for people contracting infectious diseases, for folks to prevent fatal overdoses, is to provide them with information. And that's exactly what Kate has done here for you all here on this virtual platform. When we think about how to truly prevent places from doing that, so working on the unintended harms. How many of you all have ever said yourself, you don't have to admit it, or had someone say to you, I'm sorry, I didn't intend to hurt your feelings, right? I've said it too. I probably said it this morning. I say it a lot because I kind of screw up a lot, okay? And stepping on people's toes. But when people say that, I usually stop right at the end of that statement and say, that's it. It's called being intentional. If I'm more intentional, then I may not make that same mistake in how I engage with that person. Or think about it like this. Let's keep it real simple. When I'm walking in a grocery store and my kid hits me in the back of my ankle and I get really angry and use all the beautiful and colorful words that I have to my accessibility, right? My beautiful profanity in the middle of the grocery store. Yes, that's traumatizing because it did happen a lot. It was because they weren't paying attention. And when they say, I'm sorry, I didn't mean to, I say, well, would you please mean to not do it? Which means pay attention, be intentional. So when we think of harm reduction, a pathway to equity through the lens of harm reduction, how can we reduce the risk of spaces that are supposed to provide care? Be present with participants and clients and patients, whatever you name, your individuals. How do we ensure that everything that we're doing is in our best effort to not take away someone's basic rights? And this is how we recommend it. When we think of harm reduction, this is what harm reduction is. Harm reduction is a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use. Harm reduction is also a movement for social justice built on the belief in and respect for the rights of people who use drugs. That is found on the National Harm Reduction Coalition website. You can look it up. My definition in a healthcare setting. So this is the thing, guys. You all won the ticket, the golden ticket. This presentation was intentional for people in healthcare setting, because what we do understand and know is that there's a lot of discriminatory processes in place that are not intended to do what it's doing to people, but it's happening in spaces like what we're in today, hospitals. And no, we do not have actual staff members here other than Dr. Murphy. But the cool thing is we're planting the seed. In a healthcare setting, a compassionate, non-punitive approach that centers patient autonomy and dignity, courtesy of Sharita Walker. When I think, I know, right? When I think about what harm reduction truly means, another quote that resonated that I created for myself is, when we release the focus on maintaining compliance and recenter the focus on relationship building, we are actively reducing the likeliness of discriminatory behavior. My platform when I ran for office was people over policy, people first policy. when we really look at building relationships, right? What is that? The other cool thing about harm reduction is how we practice it daily. How do you practice harm reduction daily? Just a couple of people. Tell me what you do in your life to reduce whatever harm in your life. You can yell it out.
Or a seatbelt.
You wear a seatbelt, and I hope to God everybody in here is doing it, right? So you wear a seatbelt. Who else is practicing harm? I wear flat shoes. You wear. Poor Erica. That was my colleague, you guys, online. Erica said she wear flat shoes. Anyone else? Yes.
Bike.
Bike helmet, right? Harm reduction, we're practicing it all the time. This is one way of us reducing stigma around harm reduction, the language itself, right? I try to drink more water each day, right? I notice that I'm a caffeine addict, and I choose to use that word for myself. And that sometimes I have those headaches. If you suffer from the same thing as I, you know what I'm talking about, withdrawal. So I have to drink more water to stay hydrated because caffeine dehydrates us. The summer comes, I'm with headaches and I can't operate out in the community the way that I want. That's harm reduction, how I move, how I take care of myself. There's a lot of practices in your facilities that you're doing, right? In SSP, Ryan, what's a harm reducing practice you do at work? Do you pick up the syringes with your bare hands? Okay.
Use gloves,
You use gloves,
grabbers,
grabbers,
sharps containers.
have sharps containers, right? There's a whole process, right? Just don't go, our harm reduction practice is providing sterile syringes and that's it. Harm reduction actively is happening even in the work that we do. What about you all? In your work setting, what is something that you do sorry. Not good at this, y'all. But what is something that you do that you actively practice to reduce the risk of harm in your work setting?
The floor signs.
Wet floor signs. Oh, yeah. Do we have those? I'm just kidding. We do, y'all. What else do you do?
We disinfect our van and also use van and small space safe pesticides.
Yeah.
Just to keep a clean environment for anyone who comes in.
Right. So we practice it intentionally in this space. So my thought is, what about people harm reduction? How do we actually move and center our people when we're thinking about harm reduction? We practice these things, but what does that look like? Okay. When we think about this, we call it applying the lens of harm reduction. So we work primarily with people who use drugs. That's what our organization does. We also work with organizations who are attempting to reduce the harms within their agency. So that could be making sure their teams are engaging with participants and patients, clients in a way that leads from the lens of harm reduction. Our populations just don't surround people with living experiences, people with lived experience, and this overall safety and wellness of our community.
I would say like we focus a lot on like providing resources to those two centers, like treatment centers and things like that. But are we providing resources for when our participants experience those kind of stigma, that kind of discrimination? How they would go about getting recourse for that? How we would actually, hey, well, here's the method for you to be able to right that wrong, essentially, because that's not right.
That was great, Ryan. Next time we need you to have this mic, please. So we'll be on attention too, because we want everyone to be able to hear what's happening. And absolutely, and I do believe Kate is going to be providing that kind of information so that people know what to do if they experience these things. And I want to even kick it off with that. When we apply the lens, we think of what helps to reduce harm. So this is the fact. There are systems in place that have, as we said, practices and processes in place that have not been dismantled yet. We have not been able to dismantle all the oppressive systems. So since we have not, our goal is to educate our people. That's where the first steps are. In organizations like the ones that I heard of, our role is to do exactly what Ryan said. When we're thinking about applying that lens, I need to educate my people, not just on their diagnosis. And that's where we hit a miss in recovery programs and treatment programs, because we focus a lot heavy on people's diagnosis and completion and make sure they're successful in that, which I get it because we got an insurance company instead of bullies, right? So when we think though, wow, I like the way that my partners at Norton West Global Hospital, I like that this space is here, and I wanted to say, you know what? Let me educate my clients, my participants on how to advocate for themselves when they walk in, how to ask for this service, and if someone decides that they want to deny, these are the next steps. That's actually education. How are we talking to our participants and our clients? How are we meeting them where they're at? When I was a housing case manager, I know that there's a House of Ruth housing case manager on there. I love case management. I love to fight. And I'm telling you something, as a case manager, I love that was about fighting for people right. Oh, you don't want to give them something? Here I come. I'm ready. Oh, we're going down to Section 8. Oh, man, me and Section 8, I had a ball down there. Advocating. What I learned though, here at KYHRC, one thing that I would do over, and I absolutely love my 4.5 years at House of Ruth, but there was one thing that I would do over that if I had the opportunity. I would have taught more on how to do what I was doing. Being able to feel empowered, which is what we do here at KYHRC. We empower people. See, I don't have to go into every appointment and say, I'm requesting that you run these labs. My doctor told me I didn't need certain labs ran because my age and according to that, I said, ma'am, this is my insurance, this is my health, and these are the things I'm experiencing. I would have taught them how to actually speak to providers, how to seek out a complaint form, how to follow instead of doing it all. That's the one thing, and that's what we get to do here. When you meet people where they're at, like Jose with National Harm Reduction Coalition says, you don't get to leave us though. You meet us where we're at, but you don't get to leave them. You don't get to tell them about their diagnosis and what medication they're going to need and how they're going to get it, and not help them understand what a system is going to look like when they actually go to the doctor's office and try to get that service. We have to. So meeting people where they're at by sharing the information. Offering low barrier treatment options. And I always say to places that you are not the space. There is a space in the city of Louisville, right? That's very much abstinence space. As a clinician, if I'm thinking people-centered, people first, and I'm doing this assessment, and this individual in front of me does not meet what this standard of this facility, regardless of the fact that we're still working through policy issues and potential lawsuits or whatever to dismantle that oppressive system that is in place. For now, this person needs help. So maybe this is not the space for them. So forget trying to get all the numbers that I'm supposed to get for my treatment program, my residential facility, my organization resource that I'm providing. I'm going to look at this person and say, you know what? There is a potential option that will meet your need, because I'm thinking people first. So if I'm going to avoid something where someone's telling me that I'm going to discriminate, I am going to be found guilty of this act for violating a person's rights. I'm going to look at the individual for who they are and make sure that the service is aligned with them. And that's it. Listening without stigma or judgment. My first day at KYHRC, I remind Erica this all the time. Remember, I walked in and the volunteers and staff were sitting around making safe use kits. And I about fell out because I was like, oh my God, there's cookers, there's syringes. Oh my God, and what's the band around my arm?
Tourniquets.
Oh Lord, I don't know why I couldn't remember tourniquet. But I had to step back and I remember I just stood in the hall and I was like, I used to put people out of treatment centers for this. Prepare for failure. And what made it worse is you in treatment for 14 days at a higher level of care, so maybe a 3.5, people in treatment world know you're at the highest level of resident care. Person's about to move out into a lower level of care. You give them their bags, and now they got a syringe in here. Now we got to go through the whole treatment team because they got a syringe from when they first came in. Like I started really reminiscing and going, oh my God, all the harm I was part of. Why would I expect somebody who came into treatment half of a month ago to not have anything in their bag? I mean, if you look at my bags just a week ago, there's a whole bunch of crap in there that I forgot about. But really, and I think about that, like listening without stigma and judgment. I shared this story because there was a lot of stigma and judgment in my head that I had to really work with right in that moment. The way that I listen without stigma and judgment, if I'm all the way 100 with everyone, is I have to research. So after that situation, I really started looking up. I was like, okay, I done accepted this job as the ED. And I was cool with syringe service programs, like right on. I was like, wait a minute, we got cookers though. I was like, I gotta sit with this. I gotta sit with it. Like, we actually I looked at them, I picked it up, I was like, oh man, my hand. And I know I'm dramatic, so I need you to believe when I say I did all that. I mean, cotton and everything. If you were sitting there and you come from abstinence-based treatment world into this, it's shocking. So I had to go do research. I had to do real research to really understand what I was moving into and to lean into my assumptions. The best way to handle stigma and judgment is to challenge your assumption. Challenge it. So if your immediate thought comes up, like mine was like, this is some BS. I go, okay, Sharita, see if it's some BS then. And I found out it wasn't. I started looking at the kits that were provided throughout the other states that practice harm reduction with all forms of routes of use. And I saw the chapstick. I saw Vaseline. I started talking to people who actively use. I've never used pipes. I was like, whoa. I started talking about how open wounds occur and how people are using chicken bones. And I was like, wait a minute. Okay. All right. So we're not just passing stuff out saying you can just use. Check your assumptions. It's okay. We all have biases. We all do. If you grew up watching TV at all, or if you grew up in a time where, I'm not making fun of nobody, but you grew up in a time where all your shows are on radio, which I honestly think is pretty cool. Because we kind of moving back to that with podcasts and stuff, right? So, but if you grew up with any type of form of messaging, guess what? We got biases. We all learned about each other through reckless situations and made judgments off of different people in different communities. We all did. And we use stereotypes as joke and humor that can be actually hurtful. So if we own that, then we can lean into, well, you know what? I am going to have a bias. I didn't grow up this way. I never used cocaine, crack, meth, heroin. So I already have biases. I grew up when the song Your Mama's on Crack Rock was coming out. That's when I think about it, then I can say, well, stigma and judgment are ignorant thoughts that have not been tested out. It's a hypothesis I never even tested. So that's how we do it. Respecting patient goals, even if they differ from clinical expectations. This is the thing. We made changes at different treatment programs I was over because what I recognized is that people were either going to graduate or complete the program. You are non-compliant if you do not complete the treatment plan the way that we wrote it with you when we it's supposed to be client-centered. But you would not complete that program if you didn't stick to our standards. So we started meeting as a treatment team, me and my clinicians. And what we came up with was we're going to be real client-centered. We're going to ask people what do they want. And we would put those actual goals on their treatment plan. Now, a lot of clinicians might be like, ain't that what you're supposed to do? If you're new to this work, stay with us. Of course, it's what we're supposed to do. But the reality is a lot of organizations are not following client-first practices, truly. It's abstaining. It's for so long. It's these very rigid processes that are a lot of times delivered from boards like Kentucky Board of Alcohol and Drug Counselors. Their recommendations. So what I did was I said, okay, we're going to look at what a person is trying to achieve. Well, what if they were recommended, according to insurance, to do 28 days, but they're trying to get back to their hometown in rural Kentucky. In 20 days, they really want to be done. And what I started doing was asking my clinicians, and how does that make you feel? Does it make you feel like you didn't accomplish anything? Well, how do we know that it's really working? And I had to challenge them. How do we know treatment actually has worked? We don't know when they're in the treatment program. We know when they leave, right? Reminding them. It took us months to get to a point where a successful completion did not have to be the completion of the whole 28-day program. A successful completion did not have to be the recommendation that we had for AA or NA. It could be they found somebody in their support circle that would help them continue to live a life that's healthy for them and reduce the risk of returning to active substance use. I want to just do what I'm supposed to do on my court paperwork, and they comply with that, you've completed. We started to see our numbers go up because we were actually listening and meeting people where they're at. And we argued with the people who were taking away their rights, which were the insurance companies. And that's the thing. You do have something that you can hold on to. As we move, and we're doing good with time, guys. Any questions out there that from folks on? Okay. As we move into more of this open discussion, it's going to be guided with some questions. I learned something, Jeff Wilson at Kentucky, Kentucky Alcohol and Drug Board. He's also over another one, it's KAAP. I can't remember the full name of the act. But my first ethics training, when I got my certification, not even my license, I was terrified as hell. He scared me. I thought I was gonna walk out of there and lose my certificate. But it was so good. And what has stuck with me over the years since getting my certificate was him empowering me to really support my clients. He said that paper is your livelihood. Don't let any organization, any system take it from you. Have I had to stand up and push against practices that were unethical, that could lead to discriminatory practices? Absolutely. Is it scary? it's more scary for me to lose my $350 license that I pay for every 3 years. That's my livelihood. It's more scary for me to put my family at risk, because I simply just went ahead and went along to get along. So yes, I had to step in and I had to say things or speak up. But that's because I centered my people first. My job is to do no harm. So I practice that. So as we move into the final about 20 minutes, we have this time with Dr. Murphy, and again, we'll follow up with Dr. Stewart and make sure that he's okay. I get a little concerned because he at least lets us know. So this isn't like him. So we do hope that everything is okay. But we have some questions, and we also want to open the floor up for a discussion for you all and the folks that are joining us online. I would like to start with Dr. Murphy, sharing in medical practice, Dr. Murphy, how do you define harm reduction? And then Kate, how do you define harm reduction in your practice as an attorney?
Okay, thank you. As a physician, harm reduction, we approach any chronic illness the same sort of way, in the sense that I'm not necessarily asking for best or perfect, but hopefully better. Okay, so a lot of times addiction is treated differently. In fact, I think most of the time, outside of settings like this, it's treated differently. It's like almost like a moral issue. It's just not treated like a chronic illness like it is. The definition of the American Society of Addiction Medicine is that addiction is a chronic illness. It's a medical condition. And when you think of a medical condition, you think of there's an organ involved. In case of diabetes, it's the pancreas usually. Heart disease, there's simply an organ involved. There's a disease process, and you look to improve matters there. Sometimes you give medication, sometimes you can cure the condition. Sometimes you can just make the symptoms better. But in any way, you're moving in the right direction. With addiction, harm reduction is, I don't particularly love that term because it doesn't sound like the treatment that it actually is. You are actually improving the condition of the human, the person involved with the disease, and getting their life better. And so when I deal with somebody who's got diabetes, for example, maybe they're overweight, they're not watching their diet properly, not doing all of the things that I'm requiring them to do. Yet I'm going to approach them with dignity, approach them with not shaming them, understanding that everyone's a complex individual, and everyone's journey with every chronic disease is individualized to themselves. So in the context of learning that person, I would say, well, what things can we do to help you get better? And I might give them insulin if that's what they need to get their blood sugar under control. I might give them counseling. I might try to give them ideas about proper diet, weight loss, things of that nature. But I'm also going to treat them with again, dignity and respect. And if they come back to me, which I hope they will, if I treat them well, if they come back to me for follow-up care, I'm again treating them with dignity as human. And if they have followed through with my recommendations, I might reemphasize why that's important, educate them if I can, and let them know that I do care about them as a human being, but not penalize them, kick them out of my practice, or take them off their insulin because they had a donut, in between visits. What you do is you try to move people in the right direction. Sometimes going for best ends up harming people, when really you should just go for caring and try to move them in the right direction. So in harm reduction, in terms of addiction treatment or whatever, all of these things we talked about they begin with compassion. They begin with treating people with dignity, because within this disease of addiction is a lot of that part of the brain that allows you to have that self-worth is kind of damaged. So you kind of need to, fill that cup up a little bit if you can, by treating them with dignity, obviously. But then also offering them the treatment. And from a medical standpoint, we're thinking of things like the medications for opioid use disorder or other addictions as well. There are some other medicines out there that are not FDA approved, and we're learning about those now. Hopefully they will be FDA approved for things like methamphetamine use, things of that nature. But right now we have 3 really good medications that are FDA approved for opioid use disorders, which still is the #1 killer amongst people. And these medications are very effective in decreasing the mortality rate. Very, very effective, and it's been proven by scientific evidence. And they are methadone, and that's buprenorphine, and then naltrexone. Now, methadone is a powerful opioid. It's a full agonist. It's a bit riskier. It's a bit more challenging to prescribe than buprenorphine. You have to prescribe it at a methadone clinic right now that's licensed for that. Buprenorphine can be prescribed by any provider who has a DEA license in virtually any setting. So in their private practice, if they choose to, they can prescribe somebody the day they see them, the day they need this, the day you identify the fact that it might help them. You can legally prescribe them the buprenorphine and get them started on it. Okay. Naltrexone is not an opioid. It's like Narcan in the sense that it actually counteracts opioids. That's only for people that are already in recovery that have not had opioids in their system for a while, because that will reverse the opioid into withdrawal. But that is somewhat effective. Most effective medications, however, we've seen are the methadone and the buprenorphine. So, but that's one form of harm reduction. If we can kind of get people on those things when they're ready for them. And there's examples of that in the community that's going on now. Study projects, for example, in some settings, when an emergency EMS arrives or the ambulance arrives and they reverse somebody's overdose, they can, in certain settings, talk to the patient and start them right then and there at the emergency setting on buprenorphine and give them some follow-up. They can provide them with buprenorphine. That's I don't think that's in anywhere that I know of is the law that says anyone can do that, but there are pilot projects like that. That's an example of meeting people where they are. KYHRC used to work with Dr. Stewart and the University of Louisville and the Portland Family Clinic. They would take people as we were, distributing Narcan, doing other harm reduction things, start people on buprenorphine. If they came to us and they wanted to, we could talk to them right then and there, and then get them a record, get them signed up, and get them on buprenorphine that very day. That's another example of bringing the clinic, in a sense, bringing the care to the individual where they are. Other forms of harm reduction from a medical standpoint we've talked about include the use of the testing, medical care to look for HIV, hepatitis, things that we see in the community sometimes, and other chronic conditions as well that might come into play, like other infections and things of that nature, malnutrition. But testing for HIV, testing for hepatitis is one thing. Then we often think of the distributing the Narcan, giving them supplies of Narcan as much as they can give them, so that if they do use, and if they do use with somebody, then they will have the ability to reverse that, keep them alive, because you can't treat medically somebody who's passed away. You only treat people that are alive. And so, the Narcan distribution is an important part of it. Another thing would be the clean needle exchange. And that would be a situation where, again, you're trying to diminish the spread of HIV, infectious diseases. There are other things as well that go into play there from a medical standpoint. But it's also in a setting like this, in a hospital or in a clinic, when I start somebody and I engage in a harm reduction services like that, I want to connect them with social services as well. And then also the potential to follow up and get actual treatment. Sometimes people are not ready for MOUD of the medications or the more advanced treatments. And that's okay, because people really, they have to be ready for this. You can't force someone into this and really make it work. Very unusual, but that works. They have to be kind of at a golden moment when they're ready for that. So we want to let them know that if they want that treatment, here's how it's available. So that education and empowerment is very important. And for anybody out there who gets maybe a little turned off by the idea of giving people Narcan, they're just going to use, why don't we just let them use? Give people, why do we test them using our resources for that? Why are we using the clean needle exchange? Why are we doing all of these things? They're just going to, keep using and die anyway, right? Well, the answer is no, they don't. People that have these services, people that get the harm reduction services are 5 times more likely to engage in more in-depth treatment for addiction. That's 500 times more likely to get treatment if they engage in harm reduction. And then people that get the treatment, which we saw only about 25% get treatment now, the people that get treatment, about an 80% success rate of survival with that. So it is really, really an important base to the pathway to improving your life and being healthy. But harm reduction, again, it's not necessarily, it is harm reduction, but it's also care. It is treatment. And I think if we understand that in the medical community, it sits better. That's why maybe the term harm reduction, we have a better term for that. I think it would be helpful. But it is treatment. And again, that point to remember is that if you are engaged in this in any setting, the patients are 5 times more likely to carry on, find more in-depth treatment for their addiction.
Any thoughts on harm reduction?
Specifically as it relates to,
What do you do? What do you think harm reduction is, as it relates to the work that
I guess it's something that I was thinking about was, I spent a lot of time working as a public defender. And the ways that this comes up in the legal system, ways that we don't meet people where they are, not just in regard to substance use, but ways that we require people to meet rigid standards rather than being flexible, and how that's just it's not realistic to the way that humans are. And so I think that bringing that into changing that, I think it spread of this mindset of looking at harm reduction rather than, sort of perfect being the enemy of good mindset is something that benefit from it in legal practice as well.
Thank you. Anyone have anything you want to add to that, or? No. We got some folks that were chatting it up in here and sharing their thoughts on harm reduction. Chrissy shared harm reduction is amazing in this care and treatment of the person. I think that really resonated with Chrissy. What you said, Dr. Murphy, and also meeting people where they are, not where society wants them to be. We see them as people with hopes and dreams, not a number. Harm reduction saves lives. We give them what they need individually. Just want to share the feedback as it's coming in. Can Dr. Murphy, and these are just questions that, you could just ask. You don't want to answer, but you know what I mean. Can you describe moments where you witnessed or addressed discrimination in the hospital setting?
Yeah, unfortunately, I get that in the hospital setting, in the outpatient clinic setting too. I'm a pain management specialist, so a lot of my patients have chronic pain, and many of them are on opioids. Some of them have had issues with their pain medications, and I put them on buprenorphine or Suboxone because it's actually a pretty good pain medicine too. And when somebody has a condition where, I want them on a safer medication, they might have an opioid use disorder. The option of using Suboxone for both treating that condition, the opioid use disorder, as well as the chronic pain, is a great tool for a physician to have. In Indiana, to my knowledge, it's okay to do that. In most of the country, it's okay to do that. In all of the VAs around the country, which is the largest hospital system in the world, our VA system, it's okay to do that. In the state of Kentucky, it is against the law to treat a patient with Suboxone for their pain. I'll say that again. In the state of Kentucky, where we have a huge overdose crisis, where addiction, we've had some improvement recently, but we're still, the overdose rate is ahead of pre-COVID rates. So if you take the COVID bump out of there, our overdose rate has not gone down, it's gone up. I'm sorry. I like taking victory laps, but we need to take a victory lap when it's earned and deserved. We have a lot of work to do. Our rate is still higher than pre-COVID levels for overdoses. Yet, in the state of Kentucky, it is illegal to use Suboxone to treat somebody's pain, even though it's a relatively safer drug. But I was just, a doctor just called me today on the way to this meeting. And the patient had moved to an area of Kentucky out in more rural area. And the doctors there, the pain clinic there, because this patient was on Suboxone for both pain and opioid use disorder, would not take this patient on. So you have to come off that Suboxone. We can't do that. And part of me was thinking, well, could be stigma, could be some ignorance on the part of the providers, but could also be self-preservation on the part of the providers because they're afraid that if they were to get the regulators were to come down on them because they were treating the patient with, by the way, what the evidence says is the best treatment in probably her case. But if they were to do that, they could be sanctioned. They could lose their license. They could lose their ability to take care of all their patients in their community because of the regulations. So that is one specific instance that happened today. Somebody called me and asked me for my advice on that. I'm not going to tell you what the advice I gave them exactly, because that's between me and that doctor and that patient. But it came down to the basis is, you have an obligation to put your patient's well-being first. And you can work within the context of what you've got. Put your patient's well-being first. And then also as a physician, we have the obligation to, if we find that the laws are unjust, we are ethically required, by our code of ethics to work to change those laws. So that's again going back to what's happening on June 27th with this meeting at the Zoom meeting, which anybody listening here can sign on to and participate in. But we're working to change that. So yeah, I had an instance today on the way over here where I saw discrimination.
Wow. Have you, anyone in the audience, have you experienced, a situation where you witnessed or addressed discrimination in your setting? That you could share, you don't have to share if it was current or a previous space of employment. Another question, because if this was supposed to be you and Dr. Stewart, so you could throw it at him and let him know, okay? How do you balance, and you kind of touched on this as you've been sharing, but I guess more intentionally, how do you balance medical responsibility with meeting patients where they are? And you have been touching on it, but I think just to highlight, and I think this would be beneficial for, I've done a couple of trainings for licensed clinicians, like myself, to balance their ethics and being a clinician in this field. So this could be for anyone because we all in this field, if you're certified, you have an ethical board that you know, and I just want you to share on it.
Well, a few years ago, I was giving a talk to a lot of physicians. It was a Norton seminar full of physicians. And something happened that's happened on numerous occasions when I've given talks about regulations and how we can comply with those. Because I've done that for the medical board. I've done talks and seminars on regulations for prescribing that have been, blessed by the medical board and used for their continuing medical education requirements. But they're my own presentations I put together myself and not medical board presentations. But I was talking about all the requirements, all the things you have to do to legally prescribe these medications in Kentucky. And I wasn't touching as much on the medical aspect of it. I realized that I've talked for an hour and 3/4 of what I've talked about is about regulations. And I really should be talking about what the medications do for people. And when I give talks at the University of Louisville, medical students, I give lectures there as well. It bothers me that I have to do probably half the lecture on what the regulations are, when it should be maybe 5% on that and 95% on how to treat patients and the medical use of these medications and actually treating patients with addiction. But I had, toward the end of my talk, this doctor in the front row who was well known amongst the group as a prominent physician in the community, raised his hand and stood up and he said, "Dr. Murphy," and loud enough to where everybody could hear it. "So let me get this straight. If I don't prescribe this medication, I don't have to worry about these regulations, right?" I'll tell you this, I gave the worst answer I've ever given at a conference. I told him, "No, I guess not." And I have regretted that statement many, many times because that in a sense is true. He sat down and said, "That's all I wanted to know." He sat down and I lost the whole group there. And what I would say to people that are in difficult situations like Kentucky and other states, other places where there's stigma, and not just in states, but in cities and municipalities and places where there's ordinances about these things. And it's in Indiana too. I mean, every place has these issues with understanding this. I would say, don't necessarily, break the law, but learn what it actually says. Because generally, you can find ways, it takes a little more effort, but you can find ways of getting the patients at least adequate care. If you just do the extra effort to read the regulations, understand what you're allowed to do. And frankly, I've spent a lot of time defending doctors as well. People contact me and say, "Well, I've got in trouble. Can you help me out? Can you write a letter?" Whatever. And it's always so helpful if you just explain why you did what you did. Take it back. I made this decision because I felt it was in the best interest of my patient, and explain just why you did that. Usually the regulators, I would say usually, they're people too, they're gonna understand that. It's when you don't take the time to read the regulations. And you can find them in Kentucky, they're on the medical board website. They're kind of hard to get through and they're kind of confusing sometimes, but don't just shy away, don't just do it. Take the effort to read it and make the effort. And if you're in a state like Kentucky where it's difficult, and we hope it gets better, but you have an obligation to treat suffering, and these people are suffering. And, you know, in the context of where you are with the regulations you have in front of you, just read those, learn those, do the best you can. Don't say, that's all I wanted to know. I'm not going to treat now. I'm not going to do it. Because we have an obligation to alleviate suffering. And these people with this condition is a medical condition that is legitimate and it's important and it's as worthy of treatment as any other condition that we treat.
Thank you. I want to open it up to the floor because these other questions really centered around the hospital staff. So I want to segue as we prepare to close out. And Kate, feel free to jump in. Okay. For our guests, there's a question around, you know, what have you seen in your own institutions when we think about discrimination? But I'll couple that with another question in the event that question may put people at risk for exposing things at their, you know, workspace. What would harm reduction look like in your space? When you think about the practices of harm reduction and being intentional, I would love to hear people share what would it look like to start practicing harm reduction? And that could mean looking at a particular policy or a practice that you do today and you could even use this as a work group to share about a practice that you're not sure that could be kind of borderline discriminatory, but you're not really sure. Some things are not discriminatory. It's just a part of an organization's platform. So this is that opportunity to kind of talk about that. So what would harm reduction look like in your space? And is there a policy or practice that you think you could look at or share with your leadership about taking a look at?
I'll tell you what I think it would like in hospital setting like this.
Okay.
Okay, in like University of Louisville or Morton's or Baptist or any hospital setting around the state, harm reduction would look like when people come to the hospital for whatever reason they have, we ask them about substance use disorder, we ask them about addiction, we broach the question. So in a very non-judgmental way. And then we work to help, you know, we can make a diagnosis and you know, connect them with treatment. We do. But if they're not ready for treatment, we still connect them with harm reduction services in the community. So it should be a policy in the setting that, you know, we do understand that things like, you know, clean needle exchange, getting Narcan in the community, somebody's going to continue to use. We don't just say in a setting like this that, well, okay, you're not going to follow our directions. You're not going to do what we think is best practices, best care. We understand that nevertheless, we still want you to know that we care about you and that here are the resources available to you. Here's harm reduction services for you. Here's where you can get needle exchange if you need to. Here's where you can get Narcan if you need to. Here's where you can get testing if you need to and other services. So it would be providing access to people in the hospital setting, you know, when they come in for whatever reason.
I think we have a comment on here as well. Chrissy said, we are evaluating our entire workplace leadership and policies to ensure that people with lived experience are heard, supported, and valued in professional spaces and beyond. Thank you, Chrissy, for sharing that. And similarly, we're doing something similarly at our organization. Because harm reduction is an intentional practice. So there are spaces that practice harm reduction that are not effectively practicing that internally. So there's still some pretty harmful practices going on in some of the spaces that do the work in the name of harm reduction. So just to be clear with people. But that's what we've taken on an approach of having our team involved in building our employee handbook, rebuilding it to present to our board. And that came out of just watching different situations coming up in our agency, and some things aren't found in the handbook or it's vague. It puts us at a real risk, right, for people to feel discriminated against, even though the intent is absolutely not to. But that's something that really sat with me, looking at our policies and procedures and looking at our handbook and feeling that there's something not happening. And then I was like, oh, that's right, I don't have to do it by myself. So like Chrissy said, involving people with lived experience or living experience. The people that this is going to impact the most, which are my team members, right? Not just our leaders. So that's something that you can do. And so when I think about the people in the room today, and I think about roles, you know, what could you in these last few minutes, Kate, share? A lot of us showing up in this space are a part of teams. We're not technically a part of the leadership that can, that have the power to change an entire policy that we know is harmful, right? Like they're not at that table. So what could you offer to folks who don't feel empowered to really raise their voice, or could be a risk? As you notice, not a lot of people are going to say things because, I mean, let's be honest, I'm not going to put myself at risk, even if I know something's not quite right about the way that my agency or my facility is operating. So what can a person do when they are aware, especially when it's considered residential treatment and treatment spaces that don't have enough, don't have enough eyes on them, in my opinion. How can we help our people who show up to these spaces and have to go back sometimes to spaces that are not operating in an ethical or in a way that supports our rights?
If you see something that bothers you, you can reach out to us confidentially and, we can look into what it is that's going on. And, again, this is not something that we have to do alone. So reaching out for help. And you don't have to understand the ins and outs of, is this discriminatory or is this okay? There are impact litigation is a way to address that. And sometimes we don't have a legal precedent to say this is discrimination. And so we create that case by case so that we have a landscape where that it's known it's not okay to happen and we can enforce the law. So I would say if you see something, whether or not you recognize that it is a problem, if it's bothering you, reach out.
Thank you so much. Go back up, Morgan. Thank you so much for coming to us and creating an opportunity, Kate, to do this collaboration. This webinar is, it has been recorded, so we'll be able to view it. So this is some of their ones. I appreciate you so much. And thank you, Dr. Murphy, for representing, our doctors that work in this work. We need your voices. We need your advocacy. Do not forget to go to our Facebook page and sign on and register for the upcoming, session, right? To everyone here, again, this is going to be the first of many. We are really amplifying our education panel, like a pillar, I mean, with KYHRC, Engage, Educate, Empower. We're really doing a lot in this education with the podcast. Henry, our board chair, and myself do bi-weekly. We just did the first in-person live taping of a podcast, and it was really, really good. Check it out. It's on YouTube as well, and on Spotify. We will be at several conferences coming up, presenting. So we're really trying to spread the message of what real harm reduction looks like, and it looks like this. We don't work in a silo. We work with our medical folks. We work with law enforcement. There's a big misnomer that people don't think we do. I didn't say we do it well all the time. I mean, I'm still working on building my rapport and relationship. We're still in engaged, pillar, but that's what we do. It's all of us together. So a couple of things. If you register for this webinar or in person, you will be able to get access to the slides from the webinar, which also has Kate's information and contact information. It has Dr. Murphy's information, and it will have mine and KYHRC's information. We're also going to provide you with a survey link from SurveyMonkey that we're hoping that if we could get that information back by the end of the week. It's short, it's real quick. But we want to start collecting information on how to improve or what other topics you're interested in. And if you're interested in collaborating, again, I would like to collaborate. I'd like for partners to get up here with us and do these. There's a lot of information, a lot of things that people don't know that's going on, and it's going to take us coming together to do it. If you are online, and for folks in space, we have our donation cards. We're going to always have those out. Because harm reduction really is founded in community. It was never really supported by any government agency. When you look up how people have operated in harm reduction, they just believed us when we started doing the work. So when syringes were being exchanged, and they call it the needle exchange, that came from the streets, boots on the ground, people with lived experience. And then public health was like, wow, this works. So it wasn't the other way around, okay? So just want to let people know that harm reduction is actually something that's supported by the community. And this year, we're really going to be reminding people where the heart of harm reduction comes from, which is community support. $1, $12. I mean, I think about my coffee, when I put back into my own agency, which I'm talking about KYHRC, and I donate my money, it's like, okay, I'm not gonna go get blue and silver black coffee. I'm gonna cut out one of my things, one of my addictions, and donate. Because I know that one day we're gonna be in a situation like currently where funds will be on the line. And we need to continue to do the work. We saw the evidence of our work. To Dr. Murphy's point, we still got more work to do. Elderly Black individuals in the state of Kentucky, numbers are going up, right? We have to decrease, but we're missing a whole group of people who are not in a prevention plan demographic right now. We're really hyper-focused on youth. So remembering that we're the people that get out there and start to work on those numbers before they are actually demonstrated in the data that's collected. We've been working on this for over 10 years now. We finally get a chance to see a decrease like we did for 2024. So imagine what we would have to do. And imagine what happens when we don't have the funds. So there is a donation link online. You can go to our website. You can go to our Facebook and Instagram and see the same QR code. You can become a monthly donor. I don't have any cute little things yet to sell. Like people like, you monthly don't even get this. We literally out here doing this work, but I am coming up with some stuff. We got some cool artwork that really is our work on the ground. And I think I got an idea of some of those art pieces because we do have someone that came in, Dr. Zippel, who wants to get one of our photos, the chandelier of syringes. Yeah, if you want to check it out, go to our YouTube. Like we got some really cool art pieces. So I am thinking creatively on whoever's really about supporting us. I would love to get some of our artwork that we created from the work that we do. So yes, check out our podcast tomorrow. I will be on there, but I have a special guest that will be coming on from the Somalian community, joining me for a really good conversation tomorrow at 1:00. Our podcast starts. It goes live on our Facebook and it's going live on YouTube. Anything else, Ryan? I'm leaving out. Yes, we got information. We'll have some information in our office. So Ryan Jones, if you have, excuse me, emailed me and emailed us, called us. You have also, Ryan has a couple of hats. He's one of our admin folks, admin leaders. So he will have access to these forms if you want to drop in and get marked in. You can also get information in case leaving for us. And I think that's a wrap, you guys. Thank you so much for attending this and everybody online. Thank you guys for coming.
Thank you.